morning. I'd like to thank Coeliac UK for inviting me to speak here today. I am going to speak on the extended scope practitioner-led clinic that we ran at Altnagelvin and the structured group sessions for annual review. The team that set up the extended scope practitioner-led clinic was myself, Anne Gormley, the head of our service, and Dr. William Dickey, the consultant gastroenterologist in Altnagelvin Hospital. And what we did was set up a weekly clinic to review all his medically stable celiac patients by myself instead of him. So just a little bit about the background. The number that he had on his books was approximately 1,300. And we do have about 50 to maybe 60 new patients diagnosed every year. So there was nearly 400 patients overdue their review appointment by 12 months or more, and that was really the background as to why we had to do something. So funding was achieved from the Acute Medical Waiting List Initiative for 1 year, and we developed a protocol. The protocol included the following assessment. There are some differences to that than what we would do in a general dietetic celiac patient review. Firstly, I would have reviewed the bone scans and made the clinical decision whether to order another scan. We would have requested the vaccination if the patients hadn't received it, and then I was taking the full responsibility for interpreting the blood results, and they were signed off by me, and taking responsibility for the management of the reported symptoms and any other medical issues. So just to give you some of the outcomes, the initial backlog of the 389 patients was eliminated within the year, so from that point it was very successful. The audit of the service found it to be efficient and cost-effective method of review for the patients, and the audit period covered 24 clinics, of which 179 patients were seen. So the outcomes from it was that 11% of the patients needed to go on to see the consultant, whereas 89% were managed by myself and with or without advice from him. For the first few weeks we did try to set up meetings to discuss them, and we ended up, the communication after that was via email, and it worked very, very well. That on a weekly basis I would email him. He would still have had access to the medical notes if he needed them, and he made his decision then on whether he wanted to bring them back to his clinic or not. So from this it is known that for every 10 clinics run by myself, it would require just 1 clinic run by the consultant for his celiac patients. So I wanted to move on and just point out some of the interesting findings that we did get from the audit. Obviously, we're all aware of the increasing prevalence of obesity, and it does really show that the figures for our celiac patients are no different than the general population, with about 55% being classed as overweight or obese, and only 38% being classified as having a normal weight for height ratio. It's obvious that this trend is going to keep continuing, and so really it does mean that we have to look at the advice that we are giving to our patients in the dietetic clinic session, and I'm going to talk a little bit more about that later. It was also found, interestingly, that only 5% had a low body mass index, needing specialist dietary advice for that. As part of the review appointment process, they were all asked had they any current gastrointestinal or other symptoms, with 55% reporting that they did. There was a wide range of these symptoms, the most common being constipation, some with diarrhoea, abdominal pain, nausea. The list went on. There was some with reflux, hiccups, urgency to pass stools, vomiting, skin itchiness, tiredness, bruising and depression. But really the results from that were 53% of these I was able to address within the clinic, and the reason for that was it was sort of teased out of patients that the main symptoms were caused due to lack of adherence to the diet. And as I've said, constipation was also a big issue, so giving them simple dietary advice on that worked well within the clinic as well. 37% of patients I did discuss with the consultant, and then, as you saw from earlier, 11% he brought back to see himself. And 10% I requested the GP's input as well, because their symptoms were related to their thyroid problems and mental health problems. Okay, it is worth remembering this was still a medical clinic. It wasn't a dietetic clinic, so there wasn't a full dietetic assessment done for these patients, but they were all asked whether they had any dietary concerns, and 63% of them would have said they had, and they ranged again from constipation, weight issues, queries about holidays, queries about bone health, calcium queries, and information on oats. So for the majority of them, it took a few minutes to answer their queries. For those that I felt needed more input and it wasn't within the time constraints of the clinic, 15% I did refer on to the dietetic department for a full dietetic consultation. But, you know, it just shows that those few dietary queries, it just took a few minutes really to answer them. This one really, really shocked me, and it might shock yourselves as well. But I was very surprised at the low number of people who are a member of Coeliac UK. For all our patients, when they are first diagnosed, we do encourage them to register with Coeliac UK, and when they come back for their first review, the majority have become members. So really the problem is that they let it lapse over time. And as I say, I was quite shocked with the numbers there. They gave me a variety of reasons for it. But I do think it's really, really important to address with all review patients. It's something that probably wasn't done so much by the consultant, but I really did encourage them to join, would have given them the forms, helped with the forms if they needed it. But one thing that I do think maybe does relate to this is afterwards I did a patient satisfaction survey, and from that, one of the questions where they were anonymously asked about their adherence to the diet, only 56% said they strictly adhered to the diet. So there could be some tally between the two. Just to mention a couple of the other audit findings. The DEXA scans were reviewed for all the patients, and it was shown that 53% had their initial bone density as normal. We do ask for bone scans for all our patients except if they're under 20. So really, I know there's always debate whether all patients do need to have the bone scans done or not, but I did think it was interesting that half of the patients did have osteopenia or osteoporosis. Also, all our patients are advised to get the pneumococcal vaccination, but only a third of them actually take up on that. And of those patients who didn't have it, that I encouraged, that I could have referred them on to their GP to get them, 29% declined it again. So really, I think from that we do need to increase the awareness of the recommendation among patients and healthcare professionals. Another interesting fact was that only 34% of the patients are currently under review by our dietetic department. So it does show that there is a lot of discrepancy between, you know, the patients and where they're seen. So there really needs to be streamlining of the appointment system so that our patients are getting their medical and their dietetic review. And then finally, thankfully, 89% did not report any issues regarding their current prescriptions of gluten-free products, which conveys reasonable acceptance of the current method of prescribing. So just in summary, really all our patients had the opportunity to receive dietary advice as required, but I think the most important thing from the service was that the prompt consultant review as needed. Those patients would have still been waiting for over a year to see the consultant, whereas whenever I was able to see them and refer off the patients as appropriate, he was then able to see them within a couple of weeks. Obviously, the significant cost benefits. I cost a lot less than a consultant. And as I mentioned before, we did do a patient satisfaction survey where I randomly picked 4 patients from each of the 24 clinics. So it was 96 questionnaires went out, and 69% said they were satisfied to see a dietitian instead of the consultant. And that's bearing in mind our patients absolutely love Dr. Dickey and love to see him, so I felt quite happy with that. Unfortunately, we do not have long-term funding for this. We have recurrent short-term funding, so we are still looking for the long-term funding to keep the clinic going. The next thing I just wanted to talk briefly about as well was our structured group sessions for annual review. And again, the background of this was within the dietetic department, we had 300 patients on our annual review waiting list. So again, the problems with the backlog of these patients being seen in clinic. So we set up 3 years ago a pilot session of, we had 9 to 10 sessions run annually where we had 15 patients attending a 90-minute group session. All these patients could request individual clinic sessions if they preferred to come to clinic instead, so it wasn't that we were taking that away from them. But some of the objectives of the group sessions you can see there. The session plan, and it was based on the concept of learning through group interaction. All the patients still went through their individual care pathway when they were first diagnosed. This was specifically for their annual review. And as I mentioned to you before about the high levels of patients being overweight or obese, we did focus an awful lot on trying to teach on healthy eating, and we would use a lot of visual aids like the Eat Well plate mat, test tubes containing the fat and sugar of common foods, food labels. We do change it around every year to try and include a new task or a new game for them to get involved with. They all would have obtained written information from everything that was covered, and we also evaluated the session. So as I've said, it was a pilot session initially, but we've now run it for the last 3 years. And you can read through some of the comments that we did get from the evaluation of it. So I think for the patients who liked that type of session, it worked very, very well. And for the people who didn't want to come to the group, they still did have the opportunity of coming to clinic instead. Approximately 34 hours dietetic clinic time was saved, so 11 more clinics available annually, which obviously helped meet our waiting list targets for other patients. The benefits to the patients as described. The group sessions were shown to be positive, effective and time efficient method of review. The session plan was provided to other trusts within Northern Ireland and can be provided to anybody who wants to use it, because obviously the time-saving element that we did achieve, it was counteracted by the time it took to actually write the session plan. Thank you very much.
Questions from the floor? Front, hi.
I thought that was excellent, but I looked care for roughly 2,000 patients with celiac disease as a practitioner. 2 questions. First of all, do you do, as a dietitian, do you do blood tests on these people? The second question is that my experience is the same as yours, that 50% of these people have symptoms of irritable bowel syndrome. What happens about prescribing agents for the treatment of this? Do you do that, or does it refer to the GP, or what's the mechanism of it?
With regard to anyone with symptoms, as I said, if it was something I felt I could deal with, then I dealt with it, and if it was something I felt I couldn't, I would have spoken with Dr. Dickey about it, and he would have still had access to their notes, and from that he would have made his decisions. So quite often he would have then written back to the GP without seeing the patient, but knowing what their symptoms were, he would have written back to the GP for the GP to prescribe. I'm sorry, what was your first question again?
The first question was, are the patients having any sort of blood tests? Because in my experience, a large percentage of them are either iron or folic acid deficient, which obviously requires intervention. But I mean, if you're not going to do the test, obviously you wouldn't pick it up.
No, they all had their bloods ordered, and then I would have checked all their bloods after that. So for any blood abnormalities, I would have, if it was something like their thyroid or that, I would have written directly back to the GP. If it was something else that I felt I couldn't cope with, again, I spoke with Dr. Dickey about it. But for all the patients, a report would have went back to Dr. Dickey and to the GP.
Please introduce yourself.
Fiona Moore from Derby. With the bloods, did you do those for the annual reviews as well?
No. The group sessions, I didn't even have access to their notes. The group session was much more of a general clinic, and then if anyone at the end of it had any queries that they felt hadn't been covered in the session, we would have referred them back in then to the dietetic clinic.
And how long was actually the group session for?
It's 90 minutes.
Yeah.
Behind Jen.
Just a question about the groups. I know you said you looked at patient satisfaction. Did you look at any other dietetic outcomes at all, or record any changes in compliance pre and post group attendance?
There would have been a lot of comments made with regards, how they would have made changes to the diet and made healthier changes. The satisfaction survey now was done for the medical clinic. It wasn't done. It wasn't sent out afterwards for the group sessions. That was just an evaluation form.
Any more questions? Jeremy?
Thank you very much indeed for that. It was extremely useful to see how people are tackling this problem in different parts of the UK. Just one thing I wasn't quite clear about. The annual review sessions are on top of the annual clinic?
Well, because we don't have long-term funding, they are still two separate things. The group sessions were run by the dietetic department. The clinic sessions are still, it was a medical initiative. What would happen if we got long-term funding? My idea would be that you would do it every other year, but I just have to wait and see what is going to happen with funding.
In terms of the maths of that, then you've got 50 new patients every year that you're diagnosing, and you're then going to have to add in another 5 sessions a year, every year? So
that's
going to get
why
unmanageable
we had
after.
to move to a different system, because our numbers are just going up and up.
And are you going to be able to accommodate this for an annual review, annual sort of group session every year like this?
I would like to see it then going to, as I say, every other year.
Any further questions? Hi.
Hi, I'm Shirley James from Southampton. Can I just ask your attendance rate, your DNA rate for the one-to-one?
The DNA rate for the dietetic department is, unfortunately, it is quite high. For the group sessions, between them coming to the groups, about a third of those invited came, and about 15% requested a clinic session. So unfortunately we do have about a 50% DNA rate, but we're still giving them the options of both things. I do think things would improve a lot if the two were tied together, because obviously the people coming to see the consultant, he has a very high attendance rate, whereas if we as dietitians were able to follow through that protocol and do their bloods for them and look at their bone scans and tie it in together, our attendance rate would be higher.
And if they DNA, do you discharge them right back to the GP?
Discharge them after 2 years. We give them the option of coming the following year again. The same letter would go out to invite them again, and if we don't hear from them the second year, they get discharged, unfortunately.
Any further questions? May I ask a couple of questions? Some of my dietitian colleagues said that they thought group sessions were fantastic for the diagnosis because everybody's given the same information. But they weren't so sure that it was as valuable for follow-up, because by then each patient has their own individual problem or issues that they want to discuss. And if you ever give talks at these regional meetings, as I'm sure you've all done in your profession, you always get collared by one patient who monopolises the whole thing. So how does that work for you?
I think the group sessions work really well, because a lot of the issues that patients do have, they can help each other out. It's the things like the eating out, it's the things like, how do you cope with this situation or that situation. So within the group session there is a lot of time for them to do their own group work. It's not me talking them through the whole thing, and that's where I think they do really, really appreciate that, and that's the kind of comments we get back, that they are learning from each other. It's definitely something that we have thought about when they're newly diagnosed, running group sessions at that time, but we haven't got that up and running.
Okay. My second question comes back to, because you're unique and you've done something amazing, but how transferable is it? If I get the impression that most dietitians do not have much support from gastroenterologists, that they're out there on their own trying to do this, and if they want to go and ask a question, it's call me later, whenever, never. So how does that? So you've got someone there to support you, but if you were a dietitian and you're trying to make this work in your trust, what is the toolkit in your brain that would make that happen? Cost effectiveness?
I think it's a no-brainer that it is so cost-effective, but obviously we're still fighting to get our own trust to fund it long-term. But we are so much more cost-effective.
But you need medical support still, so how do you cost for that?
Well, he was spending, I don't know, maybe half an hour going through my emails or going through the notes. I don't know how long it took him, but I mean, that was a very small amount of time in comparison to him seeing all these patients, which he felt himself he didn't need to see. He only needed to see the ones who were having ongoing problems.
Okay. Any further questions from the floor? Joy, thank you very much.